Thank you. There have been a lot of interesting advances in clinical transplantation in the last decade, but many of these, for example, in the areas of immunosuppression or the diagnosis and treatment of rejection, tend to be published in the specialist transplant journals. The BJS accepts or tends to publish transplant papers which relate to technical advances or new donor sources, so I'm going to concentrate on those. The other point is that there are relatively few transplant papers published in the BJS. In the 10-year period here, there's 53 publications. 41 of these are original articles and 12 are review articles, and most of them relate to renal transplantation. So I've chosen three areas of interest: simultaneous pancreas kidney transplantation from non-heart-beating donors, and laparoscopic live donor nephrectomy. The first paper is from the Dublin group and addresses simultaneous pancreas kidney transplantation. If you have a patient with insulin-dependent type 1 diabetes who has end-stage renal failure, then one of the important questions is, should you give them a kidney transplant alone, or is there any added value from them getting a pancreatic graft as well? And this paper addressed that question by looking at a series of 51 kidney transplants alone and comparing these with 50 SPKs. And to come straight to the results, the panel on the left shows you the kidney graft survival, and you can see that there's no difference between the two groups. The panel on the right shows the pancreas graft survival, and I think is the most important part of the paper, really. This series is well known in the transplant community and well respected because of the fact that the early graft function was really remarkably good, with 100% of the pancreatic grafts functioning immediately, and a very low technical complication rate. And this was at a time in the UK when there was very little pancreas transplant going on. So this is reflected in the graft survival, which is just over 80% at 5 years for the pancreas. The supposed important point of the paper was that the patient survival was much greater in the SPK group. You can see here that by 8 years, there's a 30% advantage for those patients that had a pancreas as well as a kidney. But in fact, the paper can be criticised, which I'll come to. The reasons for the difference in mortality were largely due to deaths from myocardial infarction, which were fourfold increased in the kidney transplant alone. And the theory is that it's cardiovascular morbidity that accounts for these patients' deaths. And there is some evidence, although it's still debated, that normalising glucose homeostasis can reverse some of the microangiopathic effects of diabetes. The problem with the paper is that the two groups were very different in terms of both recipient and donor age, both of which were much younger in the SPK groups. And of course, this would bias in favour of improved survival in that group. But as I said before, I don't think that's too much of a worry, because I think this paper did change practice, because at the time it was published, there was very little pancreas transplantation going on. And you can see from this graph here that over the last decade, pancreas transplantation, SPK in particular, has increased 5-fold in the UK. The next two papers are addressing the area of kidney transplantation from non-heart-beating donors. And the first paper's from Leicester, which I hope you'll forgive. This is an analysis of the long-term results of kidney transplants from uncontrolled non-heart-beating donors. And it's a case-control study with 112 non-heart-beating donor kidneys and 164 conventional heart beaters. These are matched for all the known important risk factors for outcome. These uncontrolled donors are patients who died in the accident department after a failed attempt at resuscitation after a cardiovascular event. And as such, they had quite prolonged warm times with a mean of 25 minutes. And this is the main difference between the groups. Now, this is reflected in the immediate early graft function. You can see that only 9% of these non-heart-beating kidneys were dialysis independent immediately, compared to 76% in the heart beaters. There was a higher rate of primary non-function numerically, 5% in the non-heart beaters versus 1.5% in the control group, but that doesn't reach statistical significance. And the panel at the bottom shows you that the renal function in terms of serum creatinine against time in the non-heart beaters is not as good as the heart beaters, but the increment in creatinine is only less than 30 micromoles per litre, and you can see that renal function is stable over it, certainly the first 10 years. Now, despite these poor early results, there's no statistical difference in the graft survival between the two groups. It's clear that the non-heart beaters don't have as good survival, but if you look at the 10-year results, a 10-year survival of over 60% in these non-heart beating kidneys is very acceptable. The second non-heart beating paper comes from Cambridge, and what they wanted to do was to try and determine the extent to which donor kidney disease influences transplant outcome. They compared 104 non-heart beating donor kidneys from controlled sources with 104 heart beaters. Now, these control donors died in the ITU setting of irrecoverable brain injury due to hemorrhage or trauma, but they didn't meet the criteria for brainstem death. So here the warm time is a median of 15 minutes. About half of their patients had biopsies at time 0 at implantation, and this is the added value from this study. The biopsies were looked at by consultant histopathologists and graded according to the system described by Ramuzzi, where you look at the vessels, the glomeruli, tubules, and the connective tissue, and these are graded from 0 if they're normal up to 3 for severe disease. These are the clinical results, which are very similar to the Leicester series. You can see that again the immediate function is lower in the non-heart beaters. It's half in this case, 35% versus about 70, and again a higher level of primary non-function. But despite this, the 5-year graft survival is not different, and the renal function by estimated GFR at 12 months is not different. Here's the biopsy data, which I think is the most important. There was no difference in the median baseline score between the two groups. But in the heart beating group, the global biopsy score was able to predict delayed graft function, but this wasn't the case in the non-heart beating group. In both groups, however, the baseline biopsy did predict long-term graft survival. So for each increment in the biopsy score of 1 point, there's a relative risk of graft failure of about 1.5, and this is the same in both groups. So the important conclusion was that donor kidney disease did affect outcome, but there was no greater impact in a series of controlled non-heart beating donor kidneys. To look and see what's happened to non-heart beating donor activity over the last 10 years, here are the results from the UK. You can see that there were only 50 cases in 2001 and 450 in 2009, a 9-fold increase. And I think this will continue. So again, I hope you'll forgive me for my last paper for discussing my own results, but my justification for this is it's an interesting area, and this is in fact the only randomized controlled trial in the field of transplantation published in the BJS in the last 10 years. So we randomized 84 live donors to undergo either laparoscopic donor nephrectomy or open donor nephrectomy in a 2-to-1 ratio. The laparoscopic operation was transperitoneal, with the kidney removed through a suprapubic incision with a median length of 8 centimeters. The open donor nephrectomy was performed through an average 15 centimeter wound in the loin with a retroperitoneal approach without rib resection. Here are the main outcome measures. The inpatient stay is 2 days shorter for the laparoscopic group, and the laparoscopic patients also received significantly less post-operative morphine and had lower pain scores. The panel shows you their return to normal activities, with the orange being the laparoscopic group, and you can see that these patients returned to driving their cars, exercising, and full-time employment much quicker than the open group. Now, there are some concerns over the laparoscopic approach because it exposes the kidney to the unnatural environment of a positive pressure pneumoperitoneum for quite a prolonged period, and also the first warm time, the time in which the kidney removed, is prolonged in the laparoscopic operation. So both of these could affect outcome in the recipient, and this operation could never be considered an advance if it simply transferred morbidity from the donor to the recipient. So here are the recipient results, and you can see the renal function. There's no difference in eGFR, which is stable over a 5-year period in both groups. There's no difference in recipient patient survival, and there's no difference in allograft survival, which was about 90% in both groups at 5 years. So I'm going to show how laparoscopic donor nephrectomy has been introduced into the UK. The first operation was done in 1998 in Leicester, and Nottingham followed quickly afterwards in 1999. Over the next 5 years, another 6 units introduced their programs, and then in the last 5 years of the decade, most other transplant units in the UK introduced a programme, and I apologise to Belfast for being stuck in the Irish Sea. So now we're left with 4 units doing open surgery, and 3 of these are actively undergoing training in the laparoscopic operation. So there's been a sea change in practice. Slide's stuck. So here we go. This is the effect that I think that laparoscopic surgery's had on the live donor program. It really does remove a number of important disincentives to donating. And you can see the orange bars, the increase in live donor activity over the last decade, which is 2.6-fold. And last year, nearly 1,000 live donor kidneys were done in the UK, and it's shortly going to overtake the activity from heart-beating cadaveric donors, in my opinion. So I'd summarise or conclude by saying that there's been some increases in the last decade in whole organ pancreas transplantation, non-heart-beating kidney transplantation, and live donor kidney transplantation due to laparoscopic nephrectomy. I think at the very least, papers in the British Journal of Surgery have reflected this practice, and in some cases it could even be argued that they have driven the process of change. Thank you very much.